manipulation courses. These are absolutes as far as I'm concerned for a manipulation course. And I'd like you to make sure that you do them. Show great care with all of the techniques and follow all instructions very carefully. Do not demonstrate any technique not taught in class. That's not because I'm saying that the techniques that we'll be showing are necessarily better than anything else, but we need to know what's being done at any given time. So if somebody's shown you some other technique, if you want to demonstrate that, demonstrate in your clinic and not in here, please, because we've got to be responsible for what goes on. For you as the patient or as the model, do not allow any technique to be done to you if you're not entirely satisfied with the setup. If it feels wrong, don't go ahead. There's a very interesting review done in the Fine Woodworking magazine on accidents that occurred to people, and people rang in about when they lost their thumb or their finger, you know, when they sawed it off, or when they did the router that gouged into their arm, and all of them felt that just before it happened that it wasn't quite right, but they thought, you know, they were tired and I'll just sort of finish this off. And of course it did. It took off a finger or the end of a joint or something like this. So for us, if it doesn't feel right to you as the manipulator, back off. Set it up again. If it doesn't feel right as you as the model, just lift your hand and get it set up again. And of course, as a educational thing, what we want you to do is to try and analyze why it didn't feel so great. And that's going to be very important. So number 4, don't perform any techniques if you have any doubts. And number 5, and I'd like you to be really, really sure about this, and there should be no problems. All tests and examination must be done on all participants. The only time we've had the odd person sore, we had one of the young women from Denver who it turned out had ankylosing spondylitis, which she knew, and we told her don't go ahead with but she wanted to feel what it just felt like. And so she was sore for about 3 days. And then I rang a week later, because I hadn't realized that this was happening, of course. I mean, I wouldn't have condoned that. But she just wanted to feel this. And she was a good sport, but I don't think that's right. If you've got a problem, you don't have some of this stuff done to you, even though it is very gentle. But a week later, she was perfectly all right again. So it was just sort of like a treatment soreness that had been developed, which happens with many people. But my only real problem, and I will tell you this incident, was as a young woman when I was teaching a course in Edmonton when we did it the old way. You know, so let's start with the safe areas first and gradually work up to here. So we're on the last day. Still hadn't got to the craniovertebral area, running out of time. It's better to run out of time with the 11th and 12th ribs than it is with the craniovertebral area, of course. Okay? So we still haven't got there. And they're sort of doing a little bit of revision at the cervicothoracic junction. And what happened was that for some reason, I was very confident of the person that did this. She was a very good manipulator, and it was on one of the young women who said, geez, I've got some sort of strange things happening in my head. And she said, I did feel a little click. So I said, well, just lay down for a second and I'll be back in 5 minutes. I came back and things were sort of not getting really any better. She was kind of felt she was going unconscious and all sorts of stuff, which of course, as it transpired, she wasn't. But you couldn't take any chance with us. Got on the phone, got the ambulance to come, they kind of carried her out with packs round her neck and a collar on and goodness knows what. And of course you can imagine, we've still got the craniovertebral area to do, and here we've had somebody taken out by ambulance. About 2 hours later, door flies open, in walks this therapist. Okay, I'm here to complete the course. They told me there's absolutely no problem in the emergency department. So I said, well, you're not going to do any more of this. You sit down there. Okay. As it transpired, I said to her, okay, you've got to go over all the things that were done to you prior to that particular technique. Tell me about the results of the tests. You know what she said? Well, we didn't actually get round to doing the tests on me because we were getting a little bit behind. And as it transpired, she had a bit of slackness in one of her alar ligaments. And perhaps that just put a little bit of extra stress on one of these joints and triggered off some kind of a sympathetic cascade. And that's what we sort of saw there. It's never happened since. But it was because all the tests weren't done. And so if you've got any doubt about what you're finding, with 3 of us here, there should be absolutely no problem about this. And then that last thing, that when I was reading this out, when I was in St. Augustine, Stanley Paris put this in, but manipulations are not to be performed on those who show positive findings from these tests. And of course we've got to go over these tests because this will be part of our protocol. Now then, we're going to do a Tony Buzan with our pages turned around. And perhaps no lines, so we'll turn it over. So there's absolutely nothing to block us into linear thinking. So we'll turn this over and just sort of have that for a minute. And we won't do this for just 1 second. What I'd like to do is to look at 1 or 2 problems that have occurred with manipulation. And I want you to look and see how would you have approached this a little different? Was there anything that you can see from your training that perhaps was a little questionable? And from that, we might be able to get right from the very start, do's and don'ts for this particular course. The first thing that I'd like to talk to you about is an example in the New Zealand Medical Journal, which was one of the few examples that I could find where a physical therapist produced a problem. And the article is taken from December the 13th, 1978, and it's entitled Vertebral Artery Occlusion Following Manipulation of the Neck. Here's the summary of the case. Okay, now what I want you to do then with your groups, once we've read through all these, is to try and identify, just to give you a bit of practice with this Buzan thing as well, on what could have been different. A 23-year-old woman developed brainstem infarction following cervical manipulation. Vertebral angiography showed total occlusion of the left vertebral artery with a thrombus extending into the basilar artery. The literature dealing with this rare but serious complication of cervical manipulation is reviewed. Manipulation of the head and neck is widely practiced in New Zealand by doctors, physical therapists and chiropractors for a variety of indications. There are scattered reports of serious neurological complications from this procedure. These include dislocation of the atlas, and this is an article that keeps trotting up from 1925, and when you read this, it's the most bizarre technique that you could ever imagine. There's another technique where somebody had their spine fractured, and this was because somebody stretched a patient between 2 tables and jumped on their backs from a sideboard that was close by. These are these old techniques which still keep being trotted up, bearing no relationship to what I showed on Chris. Okay, so we've got to sort of ask ourselves what was done. But these are the complications that are spoken of. Right, here's this particular case in detail now. A 23-year-old woman who was 2 weeks postpartum developed head and neck pains and was referred by her general practitioner for physiotherapy to the head and neck. The manipulation began with a provocative test in which the head was rotated first to one side and then to the other and maintained at the extremes of movement for several seconds. This produced no effect, no adverse effect. Subsequently, vertical traction combined with lateral rotation of the head was applied. Within seconds, she developed vertigo and the manipulation was stopped. On attempting to stand, she was ataxic, dysarthric, and complained of numbness down the right side of her body. She was immediately taken to the Middlemore Hospital. Neurological examination in this hospital showed that there was a normal mental state with slurred speech, lateral gaze nystagmus, lower motor neuron, right facial weakness, and mild weakness of the left arm and leg, bilateral limb incoordination, and ataxia of gait. This sort of examination went on, and I won't describe it in sort of detail, but finally they found the thrombus, and this woman was actually put on heparin and so on. The patient was initially treated with heparin and later with warfarin sodium and gradually improved. Within 10 days, spontaneous respiration had returned and she no longer required assisted ventilation. She was discharged 2 months later, at which time moderate improvement in her conjugate gait palsy and a virtual complete recovery of her left hemiparesis and a moderate improvement of her incoordination and ataxia had occurred. The paralysis of the left side of the palate and tongue and the sensory abnormality persisted unchanged. Now then, just have a think about that sort of pattern. And let's just write this one down with your colleague, okay? What were the sort of things that you noticed from that description of what was done to that young woman that perhaps was a little questionable? Can you pick any of that up? Let's get this thing, let's put a round ring, and let's put complications in terms of this round ring, and then just let yourself go in terms of what happened, what was done, what the examination was, and see if we can identify where we could have been a little different in this particular young woman. So have your central line, and let's go from there. The little tiny writing, we want big writing, big things. I see I'm going to have to really work on you. Oh, this is not too bad from Anne. She's at least writing a little bit bigger. So we've got to have big writing, and by the end of the week you'll have Buzan stuff, and it's the greatest thing. When you're giving a lecture, you sit down there and you can brainstorm for an hour and you've got this mass, especially if you've got a great big sheet of paper. What are the things that I would think about this for contraindications? One is that this young woman was 2 weeks postpartum. So we can kind of think to ourselves, I wonder about the sort of, I don't know this, I meant to ask a gynecologist about, or an obstetrician about this, in terms of clotting levels and all this postpartum. It may be that there is some significance in that. But we'd think that there might be some significance with movement. Okay, what was done? There was no description. It may have been done. I don't know from this. This is the trouble with these articles. I don't know if an intervertebral joint movement was done. There doesn't look to have been any attempt to try and identify the joint in question. We don't know anything about that. Okay, we know that some test, which was a pure rotation, which looked a little bit like the decline test a little, to get if there was any vertebrobasilar insufficiency here, and there was no result of that. Certainly, I'm absolutely certain that in 1978 there would be no stress test done on any of the craniovertebral ligaments. Now, they should have been, because we were taught these by Kaltenborn in 1972, and he'd been doing them a long time earlier. The first reference to the craniovertebral stress tests comes in about 1984 in a medical article which doesn't quote Kaltenborn, and he taught all these people in Europe these stress tests. So we don't know anything about that. This is the problem when we all look at this. All right? We don't know what kind of a subjective analysis was done, whether this young woman, if the postpartum was the main significant thing, or whether there was some other indications which we have to talk about in terms of her medical history. We don't know that from any of this stuff at all. Then, what was done? The technique included rotation and traction. Now, all of the stuff that's ever been done in terms of obliteration of the vertebral artery show that rotation and inclination like this tend in a certain group of patients to obliterate a vertebral artery. And so we're requiring the other one to sustain the circulation to the medulla and the brainstem, the posterior cerebellar area, okay? But every single case that showed obliteration of the artery with this movement and that movement were all made worse by traction. So we had a questionable patient in the sense of her medical background. We don't know about stress tests, but I can guarantee that they weren't done. There didn't look to be any attempt to try and identify the joint in question. The technique included all of the components. I'm not sure about the extension. All of the components, though, with this excluding, okay, that are very questionable and produce a problem. There was no attempt at specificity of technique. Let's say that the vast majority of headaches come from C2-3, and so all sorts of stress was put over C1-2 by this technique. And of course what we ended up with was problems in the vertebral artery extending into the basilar artery, which affected the medulla and affected the pons, and it affected all of her vital centers. So here was what Lewitt talks about, and I've written this in, and I'm going to ask you to read some of this tonight. Lewitt talks about that most of the problems are problems of technique and choice, not so much contraindications of a technique. This shouldn't have been done, probably, in this young woman. And if it was going to be done, it should have been done very specifically over one joint level only. All right, so there is one particular case in point. Here's a case taken from Lewitt's article, which you have in your book, and let me just read this out. A female patient of 35 collapsed while attending a funeral and had suffered from a Reinecke for 3 weeks afterwards. She was manipulated 3 times within 1 week by a qualified chiropractor. The patient was supine, and the manipulation consisted of rotation, reclination, and extension of the head. This was followed by a short period of unconsciousness and later by tetraplegia. Artificial respiration had to be applied and maintained for 36 hours. Recovery took several weeks and was complete 4 months later. So what are we seeing here? We don't know anything about the kind of pre-examination. We do know, though, that when we're dealing with a patient that has got a deviation, we have to be very careful if we're going to even think about doing manipulation. And certainly we would not be doing a manipulation that consisted of rotation, this thing, and that thing. It would just not be done. So here's a problem where we think about, should it have been done in an acute Reinecke? Well, I manipulate acute Reineckes, but I recognize 5 types of them, and I only do it for one type. Was that done here? We don't know those things. So this is the problem with all these things. This is probably inappropriate from the beginning to the end. It doesn't mean that manipulation necessarily by itself is dangerous. What it means is that the practitioners have got to be right on the ball, and that's what you're here for, to try and pick up this safety in terms of technique. Okay, just a little bit more. And then we will finish on this little theme. If I have, or perhaps I left it upstairs. I decided I wouldn't. Yeah, I can give you a little bit more reading to do. And I think in any way we've probably done enough of this for the time being. Just to sort of paint a picture of why we've got to be so careful. Now, a recent article by Haldeman in the Journal of Manipulative and Physiological Therapeutics on the Caudery-Quiney consequences of manipulating in inappropriate cases showed that there's very little evidence to suggest that this has ever been created. The Caudery-Quiney problems probably existed before the manipulation took place and didn't get much worse, But of course, this shouldn't have been done anyways. It's very questionable practice. But the real problems, unquestionably, are in the cervical spine, and that's why we must be so good. And that's why the whole of your training up till now, Cliff was telling me about a gateway course, or what we're calling that now, you know, the sort of first level course, where we didn't used to teach stress testings of this level because we felt we hadn't taught the biomechanics. Did anybody know what they were doing? And he found 2 cases within this group of people that had had motor vehicle accidents and who were now producing sort of symptoms with alar ligament laxity. And of course, as we go on with more and more motor vehicle accidents occurring, this is a bigger risk than it may have been 50 years ago because of the sort of stress levels that are occurring in the cervical spine. So we better be very careful. And I'll speak a little bit more about that in terms of rim fractures and so on that go on in the disc, which we know now are much more common in motor vehicle accidents than we previously thought. So I don't want you all to disappear at coffee break thinking, wow, this isn't for me, because it is. We are ending up with not even soreness from courses. But I want you to know that if we're going to embark on this thing, that it's very important. And that's why it's very important that you remember this, and you also remember this when you're doing it with your patients. Because one accident would be disastrous for the patient, it'd be disastrous for you, but also it'd be disastrous for manual therapy in North America, and perhaps in the world, because these things get touted around. And that's why we've got to make sure that we are so good if we're going to do this. And I think that knowledge, what we have, and the things that we do are very important. Now, with Bill, I don't know where this, in Washington, where, you know, physical therapists aren't allowed to do chiropractic manipulation. Of course, no physical therapist wants to do chiropractic manipulation. Physical therapists want to do manual therapy manipulation, the manipulative therapy techniques that we have developed. And they're not just techniques that we have developed, it's a whole philosophy of approach in terms of the scanning examination, which is pretty well the thing that was given to us by Syriacs, that set us free from many of the worries that we would have of not being able to know what was going on. That was this wonderful plan. And then as a result of a lot of other people that have put in techniques of examination of intervertebral joint motion, and then onto specific things for vertebral artery and stress tests and so on. And then we've got the specific ways that we are going to restore movement. And in manual therapy, in terms of peripheral joints, what are we looking at? We're looking at restoring distraction, and we're looking at restoring glides. And that's what we're going to be doing with the spine. It's distraction and it's glides. And that is manual therapy, manipulative thrust techniques or impulse techniques. So this is what we're embarking on in the next 6 days. I'd like you now to have just 3-4 minutes, okay? Not this miserable specimen of Dave here, but a large thing here, and block capitals on what are the key features of what we spoke about just now in terms of the contraindications. Now I'm going to come round with my ruler, and if anybody does these little things, I shall tap them on their knuckles. All right? The important things of this last little bit, then we'll have a break. The Buzan system, excellent, big stuff, good. Once we get further, we'll need bigger and bigger sheets of paper as you start getting better and better at this. Right, I'm just going to subject you to 2 other things before the coffee break, just so that you can go and enjoy your coffee. This is 2 case articles taken from Schmidt. I just want you to listen to this, because this happens so much, and we'll talk about this later in the week as well. A 67-year-old man was twice subjected to cervical spinal manipulation because of long-standing neck pain. After the first session, with jerky traction and rotation of the head, his neck complaints had worsened. Therefore, the manipulation was repeated. Now, why would, and this happens so much, And there's a case history that I've given you in the notes where, you know, a fellow calls in his colleague who is also puzzled by this and repeats the manipulation to see if he gets the same astounding dizziness and lack of unconsciousness. I mean, a lot of this is if you just stop doing it, it would be very beneficial to this patient. During the second treatment, the patient experienced a sudden crack in his neck, followed by severe pain and marked restriction of head movement. And so what turned out here was this fellow had a cervical metastasis, and his C1 was fractured. But you know, we look at this and we wonder, what was done here? Jerky traction and rotation of the head? How much velocity was put on there? Was it a little impulse? Or was it somebody reefing around on this neck? We've no idea from this thing. It could be this is just a ghastly description of something that never should have been done, and when it was done in a very unskilled way. We don't know this from any of these things. A 35-year-old woman. It's interesting how the chiropractors and physical therapists come up. Do you know Dr. Patine, Chris, from Eindhoven? He's with the Medical Institute there. But this is the sort of arrogant stuff that you occasionally come up in medical articles. Okay. It's interesting in all of these things, the nature of treatment or the therapist in terms of accidents. Chiropractors 85, and this is the number of cases that were described. Osteopaths 7, physical therapists 6, unqualified 3, not specified further 23, auto manipulation 2, unknown 3. Do we see any medical doctors there? Perhaps they're not specified further group of 23. Okay? And here we have something that's taken talking here. This is Patine's article. That's the Manual Medicine Foundation in Eindhoven. On a basis of inquiry among members of the Swiss Medical Group for Manual Therapists, Wojciak observed serious complications in 1 in 400,000 manipulations. An inquiry among Dutch members, this is all medical doctors, okay, because I'm going to give you a little thing a bit later that you'll sort of listen to this. An inquiry among Dutch members furnished incomplete data because of a low 30% response rate. Nevertheless, no complications resulting from manipulation were found. Perhaps the 70% had complications. Who knows this? And only the ones that had none responded. No data, listen to this arrogance. No data referring to complications during manipulative therapies by physical therapists are available in our country. Unfortunately, high velocity, low amplitude techniques are also used by physiotherapists in Holland. Here, there's no evidence to suggest that anybody does any harm, and yet they make this kind of statement. And this is what we're fighting about all the time. And that's why we've got to be so good. And that when we're in and demonstrating, our techniques have got to be different, and they've got to be dependent on all kinds of examination, and then when we come to do it, it's just this. It's not some major velocity stuff. That's got nothing to do with how we conduct ourselves. Anytime. And I think that when we look at some of these articles, we'll realize that we could all get into a problem. I'm not saying that. And this is not a benign technique. But in fact, if we're doing it properly, with the full background, and then we've got skill, and we come from mobilizing. If I've taught, no, I don't do it now, but I've taught in the past doctors' groups, they're not interested in doing all this. They're not interested in learning mobilizing, even for 20 minutes. They want to get in and doing the thrusting. Now, we don't do that. We learn through our whole process. In Chris's case, it's telling you it takes 6 years. When you look back at the training that you